notice it, I will address it. I will address it right away. So I'm getting ready to get started, and I see Sarah Wright from Central District has joined us, so that's great. Okay, Idaho Public Health Update. Got a lot to talk about. So, all right, so a couple things top of mind that I want to include. Certainly, if there's something I'm not even covering in here that you were hoping to hear about, please feel free to, again, ask me about it or throw it in the chat. Certainly measles, and we had a little event, not yesterday, but it feels like yesterday, last week in Idaho, so I'll talk about that a little bit. Talk about bird flu, just kind of make sure you're up to speed on that. It's been around for a while now. We've been thinking about that for a while, but just kind of what's the latest. Summer coming up, so certainly in public health, we're starting to focus on, we have messages on our websites and so forth about just, mosquitoes and ticks and so forth. It is that time of year. People are obviously getting out there. Immunization rates, what's going on in general, and then some around that, some changes to vaccine recommendations and how they're made, which was hot off the press yesterday. Some of you guys may have heard that RFK Jr. made an announcement yesterday. So things are really changing fast there, and just kind of wrapping that up into kind of a changing role of public health in general. So measles, just a quick review. Most of you know most of this, but just a reminder, the reason why being born before 1957 means you're kind of get a pass, so you're considered immune against measles. If you're like a healthcare worker, for example, where we are checking everybody's immune status, because everybody used to get infected. So pretty much being born before 57, you got it, you're immune. And it is so highly contagious that it was just universally common. There's usually a 10 to 14 day incubation period. Anything longer incubation period is a challenge for public health, because if someone gets exposed to somebody and they get sick within a day or two, like might happen with flu or COVID or some other infectious diseases, that makes it pretty easy to go, oh, you gave it to so-and-so who gave so-and-so, a couple days later. But 10 to 14 days and even up to 21 days can be how long measles takes. So by the time you figure out there might have been an exposure, that person is maybe back in their home state, or they've gone off to summer camp or whatever. Very challenging, this long incubation period. Starts with a fever, which of course, could be anything, but people that have seen a lot of measles say kids with measles generally, and adults, of course, less commonly, but really look sick. They don't have that sort of, I've got a rash, but I feel fine. They really look pretty toxic usually when they present for care. High fever, cough, runny nose, red watery eyes, and then the rash might not appear. At that stage, it's very hard to diagnose, but then the rash appears, and usually initially, of course, around the face, the hairline, and then descending. And of course, they could show up prior to that rash, in which case it'd be very difficult unless you knew they'd been exposed to measles. That might get you thinking. The complications is the reasons why measles is so worrisome. And you'll see from some of the data from the outbreak in Texas right now, this is about what they're seeing. A lot of kids getting hospitalized with pneumonia. I haven't heard of any reported encephalitis cases per se, but we have had the 3 deaths during the outbreak in Texas and New Mexico. And pregnant women, of course, have an increased risk of miscarriage, premature labor, low birth weight, and so forth. So big concern for pregnant women who are not immune and get infected with measles. The success story of measles is also kind of what's biting us now, because people haven't seen measles. 1963 is when that first vaccine was licensed, but it was just a solo measles shot. MMR as a combination with mumps and rubella wasn't introduced till 71. So people that were born, let's say in 1965 or 68 or something like that, they may have only gotten an isolated measles vaccine and not gotten MMR per se. But since 1971 and to this day, MMR is really the only available product to get measles vaccination. In 1989, because there were outbreaks starting to appear in high schools and college students and that kind of age, as the immunity from that first shot wore off. So in 1989, they recommended that pre-kindergarten dose. Excuse me, I'm having trouble talking today. 3-day weekend is really getting me, still wearing off that weekend relaxation. So in 1989, anybody born 1989 or thereafter has probably had the 2 doses that are now recommended if they had their childhood shots. And in 2000, we really quickly saw the benefit of that. Those outbreaks that were being seen in high schools and colleges and stuff, those went away. And in 2000, CDC declared measles eliminated from the United States. While I totally understand the idea of elimination, of declaring elimination, that we're making progress, we can get rid of this disease just like we did smallpox, it also has a downside. When you say something's been eliminated, it's one more challenge when talking to a reluctant parent, or a hesitant parent, is to say, well, I hear it's eliminated. Why would I vaccinate my kid against something that isn't even around anymore? So important to know that when CDC said measles was eliminated from the United States, what they mean is it doesn't circulate. It's not, when we have cases in the United States, which we of course do every year, it's returning travelers and maybe with some spread like local around that, which you can link with an epi investigation to a person who came back from Europe or Asia or Africa with that case. We don't have it where we just have somebody in the community getting measles like you would get, let's say, chickenpox. So that's what elimination means, is we don't see it circulating in this country anymore. So things looked really good in 2000, and if you look out a ways, you can see things were looking pretty good for a period after that. And the glory days really were 2000 to 2010, after elimination was declared. There was about a decade there where we had very few cases. You can see fewer than 200 cases reported every year there. And this was what elimination was supposed to look like. Yes, we still have cases, but these are those cases being brought in, importation, returning travelers with maybe very limited spread. And really in 2011, things started to change a little bit, and you can start to see cases bumping up a little bit year to year. Some years with more cases and some limited spread. In 2019, although it didn't make the news like it's making nowadays, 2019 was a pretty bad year. Not a huge outbreak like what we're seeing in Texas, but outbreaks all over the place. And there was a lot of concern that due to some dropping immunization rates for MMR and dropping natural immunity, because you didn't have people getting constantly re-exposed to measles as it circulates wildly in the wild. There was this concern that we were kind of starting to lose control of the measles situation. Then 2020 came along, and what happened was everybody stopped traveling because of COVID. Schools were closed down, people weren't socializing as much, and measles just really dropped dramatically in 2020 because of the, again, probably mostly the lack of travel. So people weren't bringing this into our country anymore. Mostly, and I want to be careful when I say that, most of the imported cases of measles in the United States since elimination are Americans who travel abroad and come back with it versus foreign-born people bringing it in. So what was seen in 2020 was that all kind of went away. But it's been creeping back since then. We started to get worried in 2024 when it kind of bumped up a little bit, and now, of course, we find ourselves in 2025 with some very large outbreaks that we're dealing with. This is just an expanded week-by-week look since early 2023, and you can really see here 2024 when it started to bump up a little bit, and now 2025, just quite an explosion of measles cases. So this is what it looks like. This is just 2025. How many cases have we had by state? This is that very, very large outbreak in Texas. There have been, of course, outbreaks, an outbreak in neighboring New Mexico, and these counties where the New Mexico outbreak is occurring, the counties actually are adjacent to the Texas county where the outbreak is occurring. It's been well discussed that this is mostly originated in a community that is pretty isolated to a certain extent, and as a group has had dropping immunization, not anti-vaccine overall, but in this particular group, the rates had certainly been dropping over the years, and almost all these cases are in unimmunized people, as you'll see. Also had outbreaks in Kansas, and I just added the numbers for some of our neighbor states, because of course we're wondering, boy, when is this going to come to Idaho? And you can see Montana has had 11 cases, and most of them have been in a county bordering ours. Again, this was a family that had left Montana, had traveled to the eastern United States and to a family event, and had been exposed there and brought it back. And then 5 cases in Washington. So we do have measles nearby, and we know that it's only a matter of time. So there's a little look-see at those Texas counties I was mentioning. You can see how hyperfocal it is. So if you have patients who are getting ready for summer travel and they're saying, well, I'm heading down to Texas, should I get immunized? You can look it up by county and kind of see really certainly it's never a bad idea, but where we really want to be careful is those babies, let's say a 6-month to 11-month-old baby, too young to get its routine first dose of measles, a dose of MMR. We would say really probably only get an early dose for that child if they were going to be traveling to one of these highly impacted counties where the outbreak is going on. We would probably not recommend it for someone traveling, let's say, to Eastern Texas, that kind of thing. There is a downside to getting that vaccine early in that the baby still has to get 2 doses after that. That first dose doesn't count because the immune system is not fully developed and may not respond well completely to it. So be thoughtful about it. I'd say take a look if a parent asks you about that, and I would only recommend it for outbreak affected counties, no matter where in the country they're traveling. Any baby traveling internationally though, 6 to 12 months, it's worth considering because measles there are outbreaks going around, including in Canada, Europe, and of course, many other countries. So the characteristics of these 2025 cases so far, you'll see it's pretty evenly distributed, sort of in age groups, a third in very young children, a third in, older children and adolescents, and then about a third in adults. Vaccination status, 96% of cases either say, yeah, I'm not vaccinated or are too young to be vaccinated, or they really don't know. They don't have any records. There's no documentation they are vaccinated. So it doesn't mean that they were completely unvaccinated, but they aren't able to verify it. And if they had one, it is probably a remote vaccination. Very few of the cases have documented MMR, but that is not unheard of. We know that a single dose is about 93% protective and 2 doses about 97% protective. So nothing's 100%, but certainly decreases the risk quite a bit, somebody who's vaccinated. The hospitalizations are interesting because, as you can see here, the rate of hospitalization in the young children is the highest by far. They tend to have the more severe measles and the more likely to have measles complications. So that is a vulnerable group for sure. We know that Idaho is a potential setup for measles outbreaks should we have it introduced into our communities. This data, whoopsie doops. This map shows reported kindergarten. These reports come. This data is important to understand clearly. When parents enroll their kids in schools, they provide immunization records to the schools, and in Idaho, fewer than 90%, that's what the dark orange means, fewer than 90% of kids have a documented 2 doses of measles on their immunization records that the parents bring in. The other 10% are either unvaccinated or the parents may have exempted but have their kid vaccinated but don't want to bring their records to the school for privacy reasons or other personal reasons. So it's not completely true to say 10% of these kindergartners are unvaccinated, but it means they don't have document. So we certainly worry that those communities might have a higher rate of unvaccinated kids. And it's just important to realize that we certainly do worry that this is just an indicator of a lower level of immunity in children in that community. This is a map of Idaho counties put together. So that same school report, I just showed you that national map. If you look at it by Idaho County, you can see that some counties have, particularly in southeastern Idaho, the schools in those particular counties have better, either more complete records or just the kids that do have the records have a higher rate of having had an MMR. But through much of the state, you can see here, we are below 90% for most of the state. And for measles, you really do want a good vaccination rate of about 95% protection to really feel like you're gonna not see spread in that community. So this just is kind of a general indicator. It doesn't mean the entire community is not protected, but it certainly means that of the kiddos, we don't have this good documentation. So just a quick refresher, because this was in your neck of the woods. Most of you are probably remember this, but I'll just quickly review. In 2023, we did have a small measles outbreak in Idaho. After not having had an outbreak, I wasn't here in 1991. Some of you might have been and might remember a very large outbreak with over 400 cases in Idaho in 1991. There were outbreaks throughout the country in this year. As I mentioned, this was just shortly after they started introducing the that second dose, and it hadn't fully worked its magic yet in Idaho. But you can see after 1991, there's been just one or two cases a year, all in returning travelers, with maybe one additional case. But in 2023, we had 10 cases. So what happened, just as a quick reminder, because I think this is a good, very possibly what could happen again. A traveler went to Europe. He was not an immune traveler. Had returned to Europe. He came back and was a little bit sick. As soon as they came back, pretty much was tested, found to have measles, but had already gone into the healthcare to seek healthcare. So there were some healthcare workers that were exposed, and there were 9 unvaccinated household members that were also in that same household, and they all got the measles. There was no spread outside of this household, fortunately, but there was quite a large investigation. Some of you may have been involved with that, with 11 staff at one medical facility, 22 patients that were evaluated because of possibly having been in the same, let's say, a waiting room, that kind of thing, and then 10 airline passengers who were on the flight with this person, because you can be infectious for up to 4 days prior to the onset of the rash. So it involved CDC and doing some airline investigations, so forth. So jumping up to 2025, I mentioned last week we had a situation, some of you may have heard about it, in our South Central Public Health District. So this is around Twin Falls, that part, kind of South Central part of the state. They had a traveler who had been exposed to the measles before coming into the US, but had 2 doses of MMR as a child, so thought they were going to be fine. This was an adult, and came here for a business trip and developed symptoms, and fortunately was wonderful, cooperated, stayed in their hotel room, kind of self-isolated, but had already been, had traveled, had already checked in at the hotel, eaten at the restaurant, and so forth. So the health district put out an alert, a press release. We were very grateful. The local media picked up the story, so that way people could be notified and aware if they happen to have been at that restaurant, let's say, at the same time. So a lot of work went into this, and so far as we know, but remember that long incubation period we talked about, 10 to 14 days, as far as we know, we haven't had any spread from that case, but that might be something we don't even find out about for another week. As a reminder, we talked about every kid should have 2 doses. And what we get more questions about is adults. Adults are like, well, I don't know. I think I had all my baby shots but I don't have records. I don't have any documentation. And what we generally say, if they're not in an outbreak area, like Idaho right now is like, peace of mind. There's no harm in going and getting a dose of MMR. They are available at your local pharmacy or at your doctor's office, but particularly if you're going to travel, especially internationally, I think it's very wise to go ahead and get a dose of MMR, unless you have records that you have been, or that you're immune, you've been tested. Some people prefer to get an immunity test. I'm like, oh, just give me a vaccine, seems easier than getting a blood draw and waiting for the results. But everybody can do it their own way. So we do recommend every adult should be aware of kind of their immune status and consider getting a vaccine, especially travelers or people living with immunocompromised people, that kind of thing. So as I mentioned, the high-risk people also include, of course, school-age kids. We really emphasize the importance that they've had their 2 doses. Healthcare personnel, of course, you all have probably gone through this, making sure you've got documentation one way or the other that you're immune. Okay, let me move on to bird flu, just a little update on that. It's kind of interesting what's happened with bird flu in this country. So as a reminder, flu, we think of it as a human disease, of course, that's us, but really influenza circulates, evolves, mutates, and really its home is in birds. And so the influenza A, that's where it does a lot of its evolving and a lot of its changing is in the bird population. Migratory birds, especially migratory waterfowl, then carry the new strains throughout the world as they migrate and bird populations move. Most flu strains don't make birds particularly sick. That's how it manages to spread itself, because those birds keep flying around, they keep pooping in the ponds and that type of thing. So they're spreading the virus. But high path avian flu is its own beast. It's got characteristics where the reason it's so important really fundamentally to humans is that in agriculture, it can wipe out entire poultry flocks. And so agriculture has always been concerned about high path avian flu. And we've been really worried about this, watching it hit other countries for years and years. And so USDA tracks new strains of flu and will test it out in experimental conditions in poultry to see if it is what's called highly pathogenic avian flu. And again, these birds get very sick, and they are all, when a bird population gets infected, they will depopulate the entire flock to try to keep it from spreading to other flocks. So as you may recall, this particular bird flu that we're struggling with now in the United States, which is H5N1 clade 2.3.4.4b, came into the US in late 2021. So you can see here the detections that were starting to be found in 2021, 2022. Commercial poultry, especially Minnesota, Wisconsin, kind of the upper Midwest here, had a lot of they had to depopulate a lot of flocks. And you started to see this in backyard flocks, especially Idaho's had a lot of backyard flocks impacted, but also detections in wild birds. Fish and Game is always surveying wild bird deaths, like what's going on, what's circulating, and then even some mammal detections. There's some very interesting maps that'll show you which kinds of mammals. In Idaho's, we've had skunks, foxes, bear, all sorts of different animals that have been tested by Fish and Game when they're found deceased and found to have had avian flu. So, but where of course it really made the news, and we've really been tracking it, is of course when it entered apparently from the bird population right into the cattle population, into dairy. And I won't go through all the history. I know that many of you have been following the history of it. But many states have had impacted dairy herds. But right now, Idaho stands out amazingly. So, in really the only state right now that continues to have impacted herds, other than California right now has one herd and Arizona has one. Last time I checked, maybe 2 weeks ago, we were at 54 herds, I think, and California had maybe 8. So for some reasons, and when we talk to our partners at Department of Agriculture, they can't really explain it to us. Why are we seeing so many more detections compared to other states? They're certainly working on it, but that's a mystery that I am hoping to hear more about from our agricultural partners. You may know that USDA has implemented a national milk testing strategy. So they're testing randomly, even if the dairy farmer says everything's fine, my cows are good, no symptoms, we're not seeing any. In cows, what mostly happens is that their milk production drops off. It gets kind of clumped. It's not, they might not eat as well, but they generally survive and recover, unlike in the birds where we're saying that they have to be depopulated. Usually the dairy farmer, the herd survives the whole ordeal. But you just have a decreased milk production. So as soon as you have a positive herd, the entire herd is quarantined until that milk tests negative. So it probably passes cow to cow in a way that is not fully understood. But the herd, multiple animals in the herd could be impacted. So right now we know that we just have 36 herds that are not producing milk for the in the milk supply and have tested positive in the last 30 days. So stay tuned on that. We don't understand why that's happening. On the other hand, as far as human cases, we've had 70 in the United States, and most of them have been in California, Washington, Colorado, and then you can see scattered about some of these other states, and they've almost all, as you can see here in the numbers, been exposed to either, these are people who either were directly exposed to dairy herds, so dairy cattle farm workers, or to poultry farms. And these are often the people going in and doing that depopulation, which is a messy business. They wear kind of hazmat suits. They certainly wear protection, but sometimes before the diagnosis is made, or maybe a mask slips off or whatever. So sometimes we do have people involved in these operations that get infected. So in Idaho, though, we have not had any human cases so far. Remember that most cases continue to be quite mild, with mostly conjunctivitis, maybe some upper respiratory symptoms, and it could easily get overlooked. by either the person themselves, who may not be very incentivized to go in and get tested. They may not want to miss work. They may be worried that they're going to be, let go if they self-report. So there's a lot of barriers to this testing. Our state lab does do testing for any dairy worker that has symptoms, but have not been taken up on a whole lot of testing. We had 15 tests done last time I checked. So not a lot, but we do continue to see human cases, but not recently in the last couple of months. This number 70 has been stable for several months now. Not fully understood. The goal of USDA is to wipe this out of the dairy population. They believe there have been maybe 3 separate introductions into, at first they thought it was 1 introduction from birds to cattle, and that would be a rare event, and they thought that'd be easily to stamp out. Now they think there've been at least 3 separate introductions. So maybe this won't work, but that's the goal. They're trying to test all the milk, quarantine the herds, keep it from spreading herd to herd, keep it from getting into the human population, and hopefully they'll be able to stamp this out. You can't get it out of the bird population, but you could maybe eliminate it from the cattle, and hopefully won't have reintroductions now with dairy farmers taking more care to keep cattle and birds and even cats in those populations, keep them separated so you're not seeing reintroduction into cattle. That's the goal. Quick reminder, if you see, let's say, a dairy worker who comes in has flu-like symptoms, it's not flu season, so you're thinking, well, that's kind of odd. And you're like, oh, you work on a dairy farm. Remember that please contact us in public health, get some testing done. Our state lab can do the testing for that. And we do recommend empiric oseltamivir or depending on the severity of the illness and if they have to be hospitalized, an antiviral, as you can see there. So please just keep it in mind, it's still here. Idaho of all states certainly has it in our dairy cattle, but very low risk in the general public. And we do have an ongoing surveillance process with hospitals where they are sending us anybody hospitalized with influenza that we've asked, and we are getting a fair number get sent to our state lab. Of course, flu season's ending, so we're seeing fewer samples as you'd expect, but we do test those just to make sure there isn't a severe type of avian flu developing out there. Okay, I did want to say a word about ticks because it's summer and I was in the Sawtooths over the weekend and I found a tick on me. Not embedded, I'm happy to report, but I was like, ah! Pulled him off and dropped him, and I looked at him, and yep, there he was, doing his best. So just as a reminder, even though when you think tick-borne disease, you really, I love this map because it just shows tick-borne diseases by kind of region, and you can see the upper Midwest where I'm from Michigan, so I always remember having ticks on me as a kid. And then of course that was before we knew about all the diseases, but they were just yucky back then. And you can see here, of course, the Northeast, a lot of tick-borne diseases, especially Lyme disease. We do have tick-borne diseases in Idaho, they'll report it every year. Of course, most famously, if you will, Rocky Mountain spotted fever, even though most cases of Rocky Mountain spotted fever are actually down in North Carolina area, but it was first discovered up here, so we're known for it. And we do see cases every year. We also have tick-borne relapsing fever. This is the soft ticks that can carry it, that when you're sleeping in cabins, they can produce a sort of a silent bite, and most people don't know they've been bit by a tick, or may come in with fevers that recur and not even realize that they've exposed to a tick. And then, of course, tularemia. So we do have some tick-borne diseases, and it's just important to be aware. Quick word about Rocky Mountain spotted fever. I already mentioned the Southeast is really where the rate is highest of infection of people. A very severe disease, can be very severe. Of course, I know you guys are well aware and will empirically treat for this. In the summer, if you see somebody with a rash illness and possible tick exposure, we do, oopsie, I kind of made my picture over the ticks here, but you can see here, we do have several ticks in Idaho that carry Rocky Mountain spotted fever. So anybody with a history of tick bite and a fever and rash, or even without a rash, think about Rocky Mountain spotted fever. On the mosquito side, a reminder, of course, our most common by far is mosquito-borne illness in Idaho is West Nile virus. We do have some others, Western equine encephalitis, for example, but West Nile virus is the most common. It can be very year to year. We can really see higher and lower burden years. This is 2024, and notably, Southwest Idaho is where most of our cases get reported from. We certainly have the mosquitoes. We have a lot of outdoor exposures. Just as a reminder, we haven't had a severe disease really. The first year we had West Nile, 2006, was a really, really bad year. Some of you might remember it. We saw a lot of neurologic cases, severe people hospitalized with meningitis, encephalitis, or flaccid paralysis, but we haven't had a really bad year like that, but it could happen again. I love this EPA site. You know, I always find insect repellents quite fascinating. So if people ask you about what to try and what to use, CDC will direct you to this EPA site, and they have a really nice, I didn't capture the entire page to look at, but you can, they have a list of all the different ingredients. Some people want a natural product, some people are more interested, does this work, does that work? It's got a really nice description of everything out there and which ones they recommend. And I think it's a great resource to send patients to that are curious, and then which ones are safe for children and pregnant women and that kind of thing. So just a reminder that this is a really great resource. Okay, so yesterday, some of you may have heard, yesterday, this was posted on X, the site normally known as Twitter, and this is RFK Jr. and Dr. Macari, the director of the FDA, and I'm going to mess this up, but it's Bhattacharya, I think, director of NIH, and they came on together to announce that CDC would only be recommending COVID vaccine now for seniors or people with underlying health conditions. And for children and pregnant women, they wanted more studies. So this is yesterday. The COVID, the Advisory Committee on Immunization Practices that CDC usually takes the recommendations from and either accepts them or maybe adjusts or declines them. That committee is meeting in 3 weeks. So I am curious to see how this decision, which is coming ahead of the advisory committee, how it all plays out. But it looks like the COVID vaccine recommendations are going to drastically change. Again, this is hot off the Twitter sphere press, so we'll see how it plays out. But we already knew things were changing. The FDA, their advisory committee met, I think it was last week. They had some discussions as well about tightening requirements and recommending that for healthy adults under age 65 that there be clinical trials done. So things are really changing in that world, and we knew that was coming. As a reminder, this is still what's on the CDC website as of yesterday. COVID is currently on the routine for anybody 6 months or older. It's on the routine schedule, also for children and also for adults of all ages. So this is going to completely change, I believe, for this new formulation that will be coming out this fall. And of course, the challenge is somebody who wants a COVID vaccine, but let's say doesn't directly fall into that risk group, but maybe they have a family member who's immune compromised, or they have other reasons they want to get it. They would potentially, the insurance may not cover it for them anymore, and they may have to pay out of pocket. That would be the type of implications. The vaccine may still be available, but no longer covered by all insurance if these recommendations actually get posted and formalized. Some of you may have seen just, let's see, that would be about a week ago now, that Dr. Macari, who you just saw, and Dr. Prasad did write an opinion piece in the New England Journal of Medicine, kind of signaling this was coming. And they were mentioning that United States really stands out, that most, well, I don't know what they would call this, most developed countries or high-income countries, many of them actually already only recommend vaccines for elderly or older. Most people wouldn't call 45 elderly, but more mature adults, or in France even 80 and older, and at high risk and high risk groups, I should say. So they made the point that they think the United States has been out of line recommending the COVID vaccine for such broad groups. So we already kind of knew that was coming. And as a reminder, this is a list of people with underlying medical conditions. So if it ends up, when we see this all in print, it might end up saying people 65 years of older and younger adults with high-risk conditions. That certainly can include a lot of people. You look at some of these conditions are pretty limited, cystic fibrosis, for example, but some are more physical inactivity, for example, is listed as a high-risk condition. So it would be difficult to say to some adult, you don't have any of these high-risk conditions. And so you'll be interested to see how that all plays out with as this moves forward. Okay, I mentioned the FDA's advisory committee, VRBPAC, met, and they did go ahead and recommend a new formula. So it's nothing very exciting here. This JN.1 lineage of Omicron, which we're still living in an Omicron world, that just got recommended. Again, it's still a monovalent vaccine. Once it's all produced and approved, this is the vaccine, the types of vaccines we'll be seeing. I didn't add this as a slide, but many of you are probably aware Novavax did get their vaccine finally fully approved, not just authorized, and so but only for seniors and I think adults with high-risk conditions, but not for younger individuals. So I've been waiting for Novavax to get approved because it's nice to give people an option. It is not an mRNA vaccine. So this is a little weird how it's kind of partly in the approved world, but partly has to do more clinical trials for younger adults and children. But it's going to be an interesting meeting coming up at the ACIP meeting in just a couple weeks. So stay tuned for that. The other quick things I wanted to mention that have just changed with vaccine recommendations. We've just talked about how babies, like let's say an 8-month-old baby who's about to go to France, or the parents are going to take them back to Indonesia or to Nigeria, that baby is recommended to get that first dose of MMR early. So that's been out there for years. But now they've added a second recommendation, which is a child who has had that first shot but hasn't had their pre-kindergarten shot, so maybe they're 3. That baby, that young child, that toddler should get that second dose at age 3, say, even though they're not getting it ready for kindergarten. They're 3 years old maybe, or 2 years old, as long as it's been 28 days. But they should go ahead and get that second dose if they're going to travel internationally. So that's something new, kind of an interesting new age group to think about possibly giving them a dose of MMR before travel. The other thing is they clarified that for nirsevimab, the antibody immunization for RSV, they really want to recommend that if at all possible, birth hospitals do that first dose. I think some hospitals have been sending patients out. I'd be interested for some of you that deliver babies, kind of what the practice is. But some hospitals have been sending the baby out for, at their first pediatrician visit, go ahead and get that dose. And you could see in many cases that might work perfectly fine, but I think they are concerned about lack of protection between that gap between discharge from hospital and getting in for that first well baby visit. There we go. Okay, I just want to wrap up. I'm getting close to where I hope we can have some time for any questions you guys have, but just a reminder, I'm always encouraging people to download Docket, the app, especially for your patients who are going to be traveling or who are going to, they're going off to college, somehow they want to have their immunization records on hand. That Docket is a nice app. The one thing that I find a little tweaky is it goes based on your phone number, and it's usually the phone number that the medical provider has for you. So some people, if you have a new cell phone number or whatever, you might be like, how do I get this to work? And you might need to ask for that with your help desk. But once you got it, it is really slick. These are some little screenshots of, or fake little screenshots. You can see it just shows you everything you have that's in the immunization registry. So very handy tool, and I urge you to use it yourself and to recommend it for patients who need their immunization records. Last thing, just a couple thoughts about changing role of public health, because you saw the RFK Jr. and now, kind of asserting his ability, which he has legal right to do, to say this is what vaccine CDC is going to recommend, but that's unprecedented, I would say. Usually they wait for the advisory committee and go from there. There's been other news stories about CDC being more silent about outbreaks that are going on, and letting go a lot of their people. And so I just wanted to speak briefly. I can't remember if I have one more slide on this. No, I'll just say that speaking to my personal experience is we've had some kind of emergency situations in the state where I thought, oh my gosh, thank God the lights are still on at CDC. They've been so helpful. They were there, they were on the calls with us, technical assistance when we needed it. But there have been other times where we have struggled to get that support that we need. And I do feel like they're a different organization now. And I think that change is continuing to evolve, as things go forward, like the announcement we just heard yesterday from RFK. Other than the Advisory Committee for Immunization Practices, I was previously on CDC's Board of Scientific Counselors, which was supposed to be this independent group of advisory people, and that has been dissolved. So whether they're going to recreate it with different advisory people, I don't know, but it is changing, and it's been it's hurting our capacity as well at state level. So just wanted to mention that. All right, I'm going to leave it at that, so that there is some time if there are any questions or comments from anyone. Abby.
Hey, Chris.
Hey, Abby.
That was a great talk. Thank you so much. Always super helpful. I guess in that vein, and I know you're kind of officially at the health department right now, but how can we as PCPs and kind of docs in the community better support you all at the moment, better support public health in our state?
Yeah, well, I'll just say some recent examples where I've just loved the support from the provider community there have been debates at the district health departments about whether to continue to carry COVID vaccine, for example. And it was really heartwarming to see the impact that providers had in Central District Health. That's the health department right here in Boise. And to really see them step up. Dr. Blue was there, who some of you know, Dr. Nekachea. I know many others sent in comments, and I think that was incredibly effective. I think that type of support, when you guys see things that are happening or discussions that are happening that are concerning, I think there needs to be voices on both sides of those debates, and the provider voice can be very, very powerful. So we really appreciate that. I know at the state level there can be things, the legislature isn't in session right now, but anything you can do to be involved, and through the IMA or through local medical societies, or just as a citizen, just speaking up about the value of health and public health. And you guys do so great work already in that area, but we really appreciate it. All right, I don't see any other questions, so I won't keep you any longer. Katrina, I don't know if you had any closing remarks you wanted to make.
Nope, this concludes our series for the academic year. Thank you all for attending when you could. And thank you so much, Dr. Hahn, for giving the presentation today. Really appreciate it.
Absolutely. And thank you. Thanks, Abby.
And
thanks, Chris. Learned a ton.
Yes, we'll have this available to share. So
great. Thank you.
okay, take care, everybody. Bye-bye.